Hi, it's Rob Timmings from ECT for Health. Thanks for joining me again for another quick Knowing Your Jargon, or KYJ as we call them. A lot of questions in my seminars around shock. In fact, I do a whole session in our trauma course and in our respiratory program and in our cardiac program. I talk quite a lot about shock. It's a really misunderstood yet incredibly simple definition, really. And I just want you to put yourself in that position that if somebody who you were mentoring, let's say it was a student that you were with, or somebody who didn't have the clinical expertise that perhaps you've got, put you on the spot one day and said, explain to me what is shock. I'm fairly certain that you would be quite confident to list the symptoms of shock, to be able to describe how you would recognise shock, but it doesn't answer the question. What is shock? Well, there's one very, very simple explanation. It's almost too simple. And you could pick up 1,000 research articles on shock and you'll get a different definition. But see how this one goes. Shock is inadequate cellular oxygenation globally. So we understand that we use a few words in our physiology in deteriorating patients. Familiar terms that you've heard, that you've used, are terms like hypoxia, hypoxemia, and ischemia. Well, let's have a look at these words and see where they dovetail with the concept of shock. If I had a single cell that had a decrease of oxygen, we would refer to that cell as a hypoxic cell. A cluster of cells that didn't have enough oxygen are literally hypoxic, or are cells that are experiencing hypoxia. If I had an entire organ or an entire lobe of an organ that was without oxygen, that was hypoxic, then the term that we tend to use to talk about tissue that is poorly oxygenated, rather than small selection of cells poorly oxygenated, tissue that's poorly oxygenated, we tend not to use the word tissue hypoxia, we use the word ischemia, which also encompasses the perfusion or the lack of perfusion of that tissue. But if every single cell in the body simultaneously was lacking the oxygen that it required for normal function, that's simply called shock. So where hypoxia is cellular lack of oxygen and ischemia is tissue lack of oxygen, shock is global cellular hypoxia. So that's our definition. Now let's have a look at the types of shock. Very briefly, we talk about shock in the context of 4 main categories. Some of the categories blend into each other, but 4 main categories of shock. To teach this, what I might do is tell a little story. So the story starts with a character. Let's call him a customer. His name is Mr. Sell. He's a happy customer because he goes shopping for the product that keeps him happy. And that product, of course, as you've guessed, is oxygen. Now, of course, he can't go to the corner store to get his oxygen. The oxygen has to be delivered to him. He's a bit of a recluse. He likes to stay where he stays, Mr. Sell. So he's going to get this oxygen, and it's going to be delivered to him. He's not buying it from the local shop. He has to get it from a supplier. Let's call the supplier the heart and the lungs. So this is the supplier. Now the supplier has a really good relationship with this excellent customer. He supplies the oxygen, the customer takes the oxygen, but it's got to get from A to B. And of course, that becomes the job of a delivery truck driver. In this story, the delivery truck driver is a fleet of delivery trucks, and on the side of the wall of that delivery truck we have RBC, red blood cell. The red blood cell, as you know, is the cell in our blood which transports oxygen. Its job is to transport oxygen from the cardiopulmonary system out to the tissues. And this fleet of delivery truck drivers does that with regular monotony along, shall we call them, major arterial highways, not to be too corny. After it's delivered that oxygen to the customer and the customer's nice and happy, that fleet of delivery trucks travels back to the heart and the lungs to become reoxygenated. Remember, it's full of oxygen here. When it's delivered its oxygen, then it's got a reduced amount of oxygen. It is now hypoxemic blood making its way back to the heart and the lungs, where it becomes reoxygenated, and the whole thing starts again. Now that's chapter 2 of any physiology textbook. That's just called circulation. We're not going to go into that any deeper. It will probably interest you to know, however, that out of the 5,500 mils of blood that's in your body right now, the distribution between your arterial network and your venous network is not 50-50. You would be forgiven for thinking that about half of your blood is in your arteries and half of your blood is in your veins, and that's just simply not the case. Your normal distribution is approximately 30% of all the blood in your body right now is doing the work of delivering oxygen. 70% of all the blood in your body right now is just making its way back to become reoxygenated before it can join this 30%. And you would be looking at that and saying, well, how can that mathematically be possible? I would have to have more veins than arteries to make that maths even possible. And, well, you've just answered the question. Of course you've got more veins than arteries. This is our normal distribution. Now, through very clever mechanisms in your sympathetic and your parasympathetic nervous system, muscles that line the walls of these veins that are carrying blood back to the heart can either constrict or dilate. And it would make simple sense, physics sense, that if I was to narrow these pipes, the volume that they would carry would reduce. So if I had vasoconstriction, as is the case when I have an adrenaline release, a flight or fight response, if I get a vasoconstriction, then it makes sense that this 70% volume would reduce. I'd have less blood in my veins, and I'd be pushing that blood, physically pushing more blood into the arterial network. And this is how it can be that when I have an adrenaline release and I get that vasoconstriction in my veins, that's why my blood pressure goes up, because its volume goes up, its tone and its pressure naturally is going to increase as a result of a simple physics phenomena. Push more blood into the arteries, it's going to be more pressure inside that pipe. This is our normal distribution. I can regulate my venous capitance. I can regulate the 70% up or down to meet my happy cells' oxygenation needs. And in a situation where I might have a reduction in, say, blood volume, I've lost some of this 5.5 litres, then my venous constriction will take place, maintaining my arterial volume. To an extent, I can lose so much blood that this mechanism fails. And we certainly see that early in shock. The vasoconstriction causes that rise in blood pressure, but then as the person loses more and more blood, then the blood pressure levels out and starts to plummet into hypovolemia. And we see that as a classic sort of stage 3, stage 4 shock when somebody's lost, greater than about a quarter of their blood volume. But you and I could quite safely lose a litre of our blood, and we won't see really any difference in here because this mechanism's going on behind the scenes. We don't look like we're hypovolemic and have lost a litre of blood because this mechanism has saved us, essentially. This is part of our normal compensation in a blood loss phenomena. So, given that these are the sort of the normal numbers, let's now have a look at the 4 categories of shock. The first category of shock is of course the one that I'm just talking about. If I lost all of my red blood cells, let's say there was a hemorrhage and I've lost all of those red blood cells, there they are bleeding out, my red blood cells are lost, my arterial network, my entire venous network, my 5,500 mils of blood suddenly plummets down to say 2,500 mils, I've lost half of my volume or more, then it would be absolutely reasonable that I don't have enough red blood cells, and you've got 75 trillion or so red blood cells, so you've got a lot. But let's say I lost half of those, then I've halved my capacity to deliver oxygen to my customer. Whilst my heart and my lungs might be able to put oxygen in the blood, I just don't have enough delivery truck drivers to deliver it. And as a result, the product's not going to get delivered to my customer, and my customer, because of hypovolemia, low blood volume, my customer is not going to be a very happy customer. Hypovolemic shocks, the first type of shock. So you can imagine that we would see that in a patient who's lost a lot of blood, somebody who's had trauma, somebody who's lost a lot of blood in surgery. Severe burns are another example of a hypovolemic shock. In certain circumstances, severe infections, gastroenteritis infections, as an example, can cause such profound vomiting and diarrhea that a person's overall total volume of blood reduces to an extent that they go into a hypovolemic shock. It's not always blood loss, it's fluid loss from this 5.5 litre volume. So that's hypovolemic. The second type of shock comes down to the heart's ability to pump. And if you haven't already checked out some of our other videos, I've done one on cardiac output and some of the influencing factors of that. Let's say, for argument's sake, I had an injury to my heart. We might call that a myocardial infarction, a heart attack. It could be somebody who's had a blunt cardiac injury from trauma, or maybe a penetrating cardiac injury. But for whatever reason, this heart is no longer able to pump the volume. I still have my 5,500 mils in my circuit. I'm just not efficient at pumping it out. My blood cardiac output reduces because my heart fails to pump that blood out. Because it's a heart-related decrease in oxygenation affecting my customer, this is called cardiogenic shock. So we see that with myocardial infarctions, blunt and penetrating cardiac injury, and other injuries to the myocardium. Severe infections of the heart, very rare cancers of the heart can cause a cardiogenic shock. It's fundamentally the type of shock that somebody in heart failure would go into. That's the second type of shock. The third type of shock affects the blood that's coming back in the venous network. And if this blood coming back into the thorax, if my blood returning from my arms and my legs and my head and everywhere outside of my thorax, if that blood was coming back via intact, open, patent venous network, my vena cava were open and functioning, then the blood would not be obstructed and could come back to my heart, then my circuit continues. But if there was an obstruction, if there was some sort of a blockage with that blood coming back into my heart, it doesn't matter how well my heart is able to pump. If blood's not coming back into the heart, then blood's not leaving the heart. It wasn't a function of the heart not being able to pump. In good faith, it was continuing to pump. It was a function of not enough blood coming back into it. There was some sort of an obstruction. This sort of shock is called obstructive shock. And we see it with a few medical and surgical or traumatic presentations. We see it in tension pneumothoraces. We see it in patients with pericardial tamponades, where they're bleeding into that pericardial sac, that fibrous sac around the outside of the heart. Obstructive shock is our third type of shock, and it relates to an obstruction of the venous network coming back in. The last type of shock is quite a large group, and this is a shock that affects this distribution, this 70-30 split. Would it make sense that if suddenly all of the veins in my venous network around my body at once suddenly relaxed, and I get a massive vasodilation? Would it make sense that my volume here would dramatically increase? Even if my 70% venous capitans volume was to increase to 90% as a result of a vasodilation event that happened in my body, what I would see is a reduction of my arterial ability to deliver oxygen. If my volume of my total blood volume went to 90% in my veins, that means I've only got 10% doing the work of delivering oxygen. When my healthy distribution is a 70-30 split, it's reasonable that if I had massive vasodilation venously, then I would have a maldistribution of my volume. This is called a distributive shock. And it happens through three main mechanisms. The first one, which I won't go into in any great detail, is called neurogenic shock. Neurogenic. And just like this word cardiogenic that we looked at just before, that means it originates in the cardio heart, a heart injury causes a cardiogenic shock. As this name implies, a neurogenic shock is a distributive shock that occurs as a result of some injury to a nerve. And the nerve that we're talking about is the spinal cord. In most instances, neurogenic shock occurs when somebody has a severe spinal cord injury that occurs above the level of T6, around about the middle of their back, their thorax. If I had a severe spinal cord injury that caused me severance of my spinal cord above the level of T6, what I actually lose is my sympathetic nervous system response below there. Now, my sympathetic nervous system is that nervous system that causes these muscles to constrict. So would it make sense that if I had an injury above T6 and I have severed my sympathetic nervous fibres, then I'm unable to vasoconstrict? The only thing I can do is vasodilate. All of those pipes getting wider make my volume larger, and as a consequence, my maldistribution takes place. That distributive shock that occurs as a result of a spinal cord injury at the T6 level or above is called neurogenic shock. A second category of distributive shock occurs when somebody has a severe allergic reaction. Without going into the chemistry of the mast cell response and histamine and leukotrienes and all of that chemical inflammatory response that is so typical of an allergic reaction, when somebody has a severe global allergic reaction response, it's often referred to as an anaphylaxis. This sort of shock is therefore called anaphylactic shock. And it's the type of shock that we see people go into when they have those severe allergies. We hear of them like peanut allergies, and some people have severe allergies to certain medications. Rarely drugs like penicillin and some of the cephalosporins and morphine to a lesser extent. Some people are so severely allergic to some things that they eat or some things that they come into contact with that they can have an overwhelming, life-threatening maldistribution of their blood volume through this anaphylactic shock. And the principal ingredient here is that with any allergic reaction, specialized white blood cells, basophils, called mast cells, release a potent chemical called histamine. It's the same chemical that we try to stop when we take a drug called an antihistamine, as an example. And what this histamine does is this histamine paralyzes these nerves that cause the veins to constrict. So if I've paralyzed the constriction vein, the constriction nerves, then my veins will relax and I get the dilation. I get an increase in volume in my venous network, a decrease in volume in my arterial network, and as a result, I'm not delivering oxygen. Anaphylactic shock kills people, and it kills people primarily through airway blockage as everything starts to swell. But you have to ask the question, where does all this fluid come from that causes the swelling? Well, it's coming straight out of the blood volume. So not only are they getting a maldistribution of their volume, but they're also actually dropping their overall blood volume as they start to shift plasma out of their vascular 5.5 litres and into their interstitial spaces that cause the classic and typical edematous symptoms that we see with somebody that's having an anaphylaxis. It would be true to say that an anaphylaxis, therefore, probably straddles two different categories of shock. It is equally distributive as it is a hypovolemic form of shock. And so is our last one. The last one I wanted to look at is septic shock. Where in anaphylaxis, it's some sort of a foreign invading protein that your body has taken offence to, has had an immune response to. In septic shock, it's often a septic pathogen. Let's say, for argument's sake, a bacteria. And bacteria, when they invade the vasculature, when a bacteria becomes blood-borne, we often refer to it as a bit of an old-fashioned term as septicemia. And the nature of septicemic bacterial organisms is that they produce toxins. These bacteria floating through your vasculature when you have a septic blood-borne infection are producing these toxins called alpha toxins and endotoxins, and they quite literally paralyse the nerves that instruct these vessel walls to constrict. Again, like an anaphylaxis, if I can't constrict and I paralyse those muscles and the nerves that supply those muscles, then I get a parasympathetic vasodilation. My vasculature starts to leak, little pores and little holes in my capillaries everywhere around my body start to leak, and a person with a septic shock, similar to an anaphylactic shock, a person in septic shock will have first a maldistribution, a sudden vasodilation, dropping their arterial blood pressure and their oxygen delivery, but they'll also physically start to lose large volumes of fluid from their vasculature. They develop a hypovolemia as well. And you'll recall when you're caring for a patient with an anaphylaxis, it's all about airway management, but with a septic shock, it's all about fluid resuscitation. Whilst we do want to get on top of whatever the bacteria is that's causing them to have a septic shock, and certainly intravenous antibiotics, multiple intravenous antibiotics are going to be used. To really save this patient's life, it's going to be about restoring vascular volume and restoring oxygen supply to our cell, which can't happen in septic shock because of a maldistribution and a hypovolemia. So that's a really, really oversimplified 7-week course on shock. 4 main categories of shock: hypovolemia from loss of blood volume, distributive from loss of the distribution 30-70 split, which is normal, a cardiogenic shock from a cardiac muscle injury or failure, and an obstructive shock from some sort of interruption to the venous capitans. That's the story of shock with Mr. Sell.